I invite Dr. Smitha to speak on drug-induced glaucoma.
Good evening all. Drug-induced glaucoma can be classified into open-angle glaucoma, especially with steroids, and closed-angle glaucoma, which can be a pupillary block glaucoma or a non-pupillary block. This is a case of 30-year-old female presented to our OPD in June 2020 with complaints of blurred vision, both eyes, and headache for the past 1 month. She is a non-case of exfoliated dermatitis on steroid treatment, systemic steroids, tab prednisolone 8 mg once daily. And on examination, her best corrective visual acuity in the right eye was 618 and left eye it was 612. And there was posterior subcapsular cataract in both eyes, and the fundus was normal with 0.5 cup disc ratio. Her IOP was 28 millimeter mercury in the right eye and 23 millimeter mercury in the left eye. So she was given anti-glaucoma medications and the IOP was under control. She underwent left eye cataract surgery in December 2021. And in November 2022, since her steroid treatment was high, her vision in the right eye decreased to 624 and her IOP was 48 millimeter mercury in the right eye with glaucomatous optic disc changes in the right eye. Her anti-glaucoma medications were high, but she was not getting controlled, and so phacotrap was advised. But she had a fracture in the right leg, and so she was lost for follow-up, and she came back in April 2023 with PL negative vision and glaucomatous optic neuropathy. She underwent phacoemulsification and trap in May 2023. This was her fundus picture. With in the right eye there was glaucomatous optic atrophy. So steroid-induced glaucoma can be a response to exogenous or endogenous steroids. It is called steroid-induced hypertension when there is rise in IOP but there is no glaucomatous optic neuropathy, and steroid-induced glaucoma when there is raised IOP with glaucomatous changes. In general population, about 1/3 population are moderate responders with IOP rise of 6 to 15 millimeter mercury, and 5 to 6% are high responders with IOP rise more than 15 millimeter mercury. The risk factors include patients with POAG, first-degree relatives of primary open-angle glaucoma patients, children below 10 years, and older adults, high myopia, connective tissue disorders, eyes with traumatic angle recession, diabetes mellitus, etc. Topical steroids causes rise in IOP in 2 to 6 weeks, and this elevated IOP correlates with the duration and frequency of administration and the potency of the steroid. And DEXA and prednisolone have higher rise of IOP, while loteprednol and fluoromethanol causes less rise in IOP. Intravitreal steroids like intravitreal triamcinolone causes rise in IOP in 1 to 4 weeks after injection, and the IOP rises about 5 to 15%. And the risk factors include younger age, high myopia, and multiple injections. Periocular route is more dangerous. It causes prolonged elevation of IOP because of the long duration of action. And systemic steroids, they are the least likely to induce glaucoma. It may take longer duration for the IOP to rise. Chronic use of systemic steroids leads to cataract and glaucoma. And steroids, when used systemically and topically, IOP elevation is additive. And the skin preparations like clobetasol, betamethasone, dexamethasone, these are highly potent, while triamcinolone is medium potent, and fluoromethanol and loteprednol are of less potency. The oral steroids, the average time taken for IOP rise is months to years, while with inhalation it takes about 3 months, and with dermatological preparations also it takes 3 months. But topical drops result in increased IOP in 2 to 6 weeks, and IVTA injection 4 to 8 weeks. Posterior subtenon injection causes IOP rise in 5 to 9 weeks. So for prevention, monitor every patient on ocular steroids regularly. First follow up after 2 weeks, and then every 2 weeks for the next 3 months. If in the first sign of steroid response, change to NSAID or low potent steroids like fluoromethanol or loteprednol. Choose an easily reversible method like oral and topical instead of subtenon and intravitreal. On chronic systemic steroid usage, 4 monthly checkup is needed. So treatment is discontinuation of steroids and control of IOP with anti-glaucoma medications. If not controlled, you can try laser trabeculoplasty and filtering surgery. Angle closure glaucoma can be pupillary block glaucoma in a pre-existing anatomically narrow angle, like with anti-cholinergics, adrenergic agonists, antidepressants, etc., or with the forward displacement of the lens iris diaphragm, as in cholinergic drugs and anticoagulants, or forward displacement of the iris lens diaphragm due to ciliocoroidal effusions, like with sulfonamide drugs. Sulfonamide-induced angle closure glaucoma is seen in antibiotics like sulfamethoxazole, diuretics like hydrochlorothiazide, anti-epileptics like topiramate and acetazolamide. This is a case of 35-year-old female presented with complaints of pain, redness, blurring of vision, both eyes, and headache for the past 2 days. And she was on topiramate for migraine for the past 10 days. And her native vision was 6/60 and -3 spherical and -1.5 cylinder in the right eye. She was improving to 6/9, and in the left eye -4 spherical and -0.5 cylinder, she was improving to 6/6. And her IOP was 60 millimeter both eyes. And there was circumcorneal congestion, microcystic edema, shallow AC with mid-dilated pupil and a normal disc. She was managed with IV mannitol, IV and topical steroids, systemic and topical anti-glaucoma medications, and atropine eye drops. She was discharged after 5 days on topical steroids and atropine, and her IOP was 6 millimeter in the right eye and 8 millimeter in the left eye. This was the slit lamp photo on the day of discharge. So topiramate-induced angle closure glaucoma, in topiramate can cause osmotic disturbance within the crystalline lens, leading to hydration of the lens and thickening, with the anterior displacement of the lens iris diaphragm. It can cause ciliary body edema and supraciliary effusion, leading to forward retraction of the ciliary body and mechanical angle closure. It usually occurs in a few patients, and the doses well within the normal range and in a normal anterior chamber depth. So it is an idiosyncratic reaction. It is usually a bilateral presentation, with blurred vision is the most common symptom, and usually presents within the first 2 weeks of use, and myopia up to 8.75 diopters is induced, and UBM usually shows supraciliary effusion. Management is discontinuation of the topiramate, anti-glaucoma medications to control IOP. Pilocarpine is contraindicated in these cases. It causes further lens iris for diaphragm movement anteriorly, and oral IV corticosteroids are given to reduce the uveal effusion. Laser iridotomy is not useful, as angle closure is not precipitated by the pupillary block, and cycloplegics should be given in such cases. Cholinergic agents like pilocarpine, acetylcholine, and carbachol causes forward movement of the lens iris diaphragm, especially in cases with zonular weakness and exfoliation syndrome. Anticholinergics like atropine, hometropine, they causes mydriasis and cause pupillary block. Antidepressants like tricyclic and tetracyclic antidepressants can cause pupillary dilatation, and antihistamines also causes pupillary dilatation. Botulinum toxin can block the ciliary ganglion and cause pupillary dilatation when injected near the eye. So patients should be counseled to seek care if any of the typical symptoms of angle closure glaucoma occurs. And at-risk patients should be evaluated by gonioscopy and should undergo laser PI prior to receiving botulinum injections. And anticoagulants causes massive vitreous choroidal or subretinal hemorrhage and causes forward movement of the lens iris diaphragm. The risk factors include exudative ARMD and non-ophthalmos. Thank you.